Well, hello and welcome to our virtual patient information session to share information about Northern Light Eastern Maine Medical Center's hernia program. In a few moments, we will introduce you to our presenters this evening, Dr. Michelle Toder, Dr. Matthew Sharbo, and Dr. Dan Heatherman, all surgeons with Northern Light Surgical Specialists, and Zena Black, RN, our patient navigator for the program, who have together put together a great presentation to explain details of our program and everything you need to know. A few housekeeping details we want to let you know about. We welcome your questions at any time during the presentation using the Q&A feature at the bottom of your screen. Zena will be monitoring these as well as the doctors, and they'll do their best to respond to them either in real time, or they may perhaps save your question until the end. And of course, we will save time at the end of the presentation for some Q&A for any other follow-up questions folks may have. At the conclusion of our virtual info session, a very brief survey will pop up on your screen. And we would just ask if you would to please take a moment or two to complete that so that we can gauge what worked well and where we might improve. And with that, I will turn things over to my colleague, Tom Violet, to introduce Dr. Toder to kick things off. Tom?
Thank you, Bob. And I want to thank everybody for taking time out of their busy evening to join us today. We're extremely fortunate to have a great presentation for you. And at this time, I'm going to introduce Dr. Toder, who will be introducing our two presenters. Dr. Michelle Toder is the medical director for Northern Light Surgical Weight Loss and is the clinical lead for our robotic steering committee. A graduate of the University of Massachusetts Medical School, Dr. Toder completed her residency training at the University of Chicago Hospital. She's been training surgeons on robotic surgery technique and performing bariatric surgery and general surgery for over 20 years. In 2019, Dr. Toder was honored for completing her 3,000th robotic-assisted surgical procedure. So I want to introduce and welcome Dr. Toder.
Thanks, Tom. I want to also thank everyone for coming tonight. It's one of those magic, beautiful evenings in Maine. So thank you for taking the time. It's my great pleasure to introduce my two colleagues who have been an incredible addition to surgical specialties here at Eastern Maine Medical Center. Dr. Heatherman went to the University of Massachusetts Medical School and completed his internship and residency in general surgery at UMass, which is where I also happen to go. So clearly well educated. He provides a comprehensive evaluation and management of what we call GERD, or gastroesophageal reflux disease, hiatal hernias, gallbladder surgery, hernia surgery, and general surgery. Dr. Heatherman works with his patients to create an individual care plan, and he specializes in robotic surgery, minimally invasive and laparoscopic surgery, hernia and gallbladder disease, as well as anti-reflux surgery. In addition to Dr. Heatherman, we had the great fortune of recruiting Dr. Sharbo, who earned his medical degree at the University of New England and completed his general surgery internship and residency at the MedStar Washington Hospital Center and MedStar Georgetown University Hospitals in DC. He then completed a fellowship at Albany Medical Center in New York, studying advanced gastrointestinal, minimally invasive, and bariatric surgery, as well as robotic abdominal wall reconstruction. He strives to use the most advanced, least invasive, leading edge approaches for those struggling with hernia or heartburn. So please join me in welcoming them both to our information session.
All right, thank you very much, Dr. Toder. I'm going to share my screen here. You should be able to see the PowerPoint now. So as Dr. Toder said, I'm Dr. Sharbo, and we appreciate everyone being on the call tonight. And we're going to have a webinar about hernias and what we offer at Eastern Maine Medical Center. So first of all, what is a hernia? Well, a hernia by definition is truly just a hole in the abdominal wall. When a hernia occurs, tissue from the inside is pushed out through the abdominal wall, and that typically happens either near the belly button or down in the groins. When tissue from the inside pushes out, it can kind of stretch the nerves and the muscles in that area, and that can cause pain and discomfort. Hernias are one of the most common general surgery procedures that are performed in America today, with over 1 million abdominal wall hernia repairs being repaired each year. I often get asked in the office, how come I developed this hernia? Or what are the risk factors for hernia? Well, typically people that have jobs that require heavy lifting or straining of the abdominal wall are at higher risk for developing a hernia. What can happen is as you squeeze your abdominal muscles, extra pressure on the inside can kind of force some tissue out some of the various areas of the abdominal wall. Other risk factors for developing a hernia are prior abdominal surgery. We know that if you've had an incision before, the tissue doesn't heal all the way to 100%, and that puts you at risk for hernia. Patients that are obese or have higher weight, it adds to some of the increased pressure inside the abdomen and can lead to hernia development. Some patients just have weak connective tissue, and we'll often see trends in families where a grandfather, a father, and a son all have hernias together because the tissue is just weak. Patients that smoke also put them at higher risk because they're more likely to cough and increase some of the pressure in the abdomen, or smoking decreases some of the blood flow to the areas of the abdominal wall, and that can put you at higher risk for developing a hernia. The symptoms that we most commonly see in the office for hernia are typically a new bulge. Very often what I'll hear from patients are, I was out doing some heavy lifting, work in the yard, or helping a friend move something up a flight of stairs, and a few days later I noticed a bulge. That bulge can often come with some weakness, meaning that when you try to lift heavy things or you contract your abdominal wall, that area can be a little bit sore. And then we often see some pain. Various pain patterns that go along with hernias are typically pain that's worse at the end of the day or doing a lot of heavy activity, or pain that sometimes radiates down into the groin, into the testicles from groin hernias. So how do we make the diagnosis of hernias? Well, most commonly that diagnosis is made by physical exam. And what that means is typically primary care providers or your surgeon will place their hands on your abdominal wall and ask you to cough. That cough can increase some of the pressure inside the abdomen and allow the hernia to come forth against the physician's fingers. If the physical exam is inconclusive, meaning you can't quite feel the hernia, some other tests we sometimes use are an ultrasound. An ultrasound is typically an outpatient test, meaning you go in, you get the test, and you leave the same day. And it's where a technician puts a special probe that uses sound waves over the area that may have the hernia. They often will ask you to cough and see if any tissue comes forth through that hole in the abdominal wall. Other studies we sometimes use are called a CAT scan or a CT scan. And that's another outpatient procedure where you come into the radiology department. You're placed on a specialty bed and you're put through a machine that takes pictures of the inside of your abdomen. That gives us a pretty good idea of whether there's a hernia there or not and what the hernia contains. An MRI can also be used to diagnose hernia, and that's very similar to a CT scan. There's many different types of hernias, and we see them all in the hernia program at Eastern Maine Medical Center. And some of the different ones we often see are inguinal hernias, meaning a hernia down in the groin. And you can see on your picture here, there's many different types of inguinal hernia, but that's typical of the groin pain that can come along with those hernias. Sometimes we see umbilical hernias, which are here at your belly button. And then another type of hernia is called the incisional hernia. Like I said on a previous slide, if you've had an incision before, the chances that you get a hernia through that incision are a little bit higher. And then we have some rare hernias that happen anywhere in the abdomen. This is a closer picture of the hernias down in the groin, which we call inguinal hernias. These are most common in men. And the reason is as we develop, our testicles descend down into the scrotum, and that creates a canal. If you see on your picture here, that's going to create a defect in the abdominal wall. And what can happen is other tissues that are not supposed to go down the canal can bulge through that area. And the reason that that causes pain, you can see these yellow lines here on the picture, are some of the nerves. As you get a bulge in that area, that can put pressure on some of the nerves, and that is very typical cause of groin pain in men. Another hernia that's very typical is the umbilical hernia at the belly button. When we're developing and we're attached to our mothers through our umbilical cord, there's a small defect at the belly button. As we grow and over time, and increased stress and abdominal pressure can lead to that small opening increasing in size, which is called an umbilical hernia. And that's one of these seen in the picture right here. The incisional hernia is typically one at a point of previous operation, and you can see in your picture down here. And that hernia can be down the middle, it can be off to the side, and it can even be down in the groin. So anywhere you've had a previous incision can lead to an area of weakness that sometimes develops a hernia. So what are your options to consider when you get a diagnosis of hernia? Well, there's many different things that we talk about here at the hernia program. Some people choose to watch and wait for the hernia. Some people, there's just a bulge and it doesn't bother them. And we know some people that watch hernias for many years. Some people that have hernias that are a bit more uncomfortable, we sometimes recommend a truss. A truss is like a piece of sports underwear that adds some extra pressure to the abdominal wall to hold the hernia in and keep it from popping out. And some people get some support from that. And the last option we typically discuss here is surgery. And if you're thinking about the different options, why should you choose hernia surgery? Well, first and foremost, some of those other options are temporary fixes to kind of hold things in place. But hernia surgery is a definitive management of your hernia, meaning we'll fix the hole in the abdominal wall. And that is much more likely to reduce the pain that people feel from the pressure and bulging on some of the nerves that I showed on the previous slides. Hernia surgery can help repair some bothersome bulging, whether the hernia is in the groin or down the midline. A very typical presentation we see in the office is people come in and say, this hernia doesn't necessarily bother me, but it's very unsightly. I don't like the way it looks, and it's underneath my t-shirt, and people can see this bulge down the middle. And lastly, something we always discuss with every patient, but is very rare, is to try to prevent hernia-related complications. And those hernia-related complications that we try to prevent from happening by fixing hernias early are when something such as your intestine can pop out through the hole and get stuck in there. If this picture here is the hernia and the hole in the abdominal wall, when something pops out and gets stuck, that's called incarceration of your hernia. If something pops out and gets stuck and then gets compromised, that's called strangulation. And though that is a surgical emergency that I discuss with every patient, that if that happens to you, you need to go to the emergency department to be evaluated. People that have this happen typically have worsening pain. They often will have nausea and vomiting, and they won't be able to pass gas because things are blocked from the hernia. So what is hernia surgery? What does hernia surgery entail if you get diagnosed with a hernia? Well, like we discussed on the first slide, hernia is simply a hole. So when we do hernia surgery, we pull everything that's bulging through the hole back into the proper cavity where it belongs, and we fix the hole and repair the weakness of the abdominal wall. You can see your picture here that is before surgery, where there's some tissue bulging through the abdominal wall. And after surgery, that area is typically flat as we've pulled everything back into the middle. There's a couple different ways that surgeries are performed across the United States. The first is traditional open surgery, where a long incision is typically made over the top of the hernia. The second way, the more advanced way, or the newer way to fix these, is minimally invasive surgery. And that can be broken down into two separate groups called laparoscopic or robotic-assisted surgery. This picture here shows a typical incision for a hernia that would be done down the midline. And you can see that there's typically a long incision over the top of that hernia. This picture here shows a typical robotic surgery approach to the same hernia. And what we do for these approaches is we typically use small incisions, which I tell most people are about the size of your fingernail. They're 8 millimeters. We put various number of incisions across the abdominal wall, and we're able to repair these through smaller incisions. Some of the benefits of using just small incisions and minimally invasive surgery most commonly includes less pain. When you make a smaller incision, the amount of tissue that gets disrupted is typically less, and that leads to less pain. People that have minimally invasive surgery undergo a faster recovery. And we know that because we often recommend an earlier return to work than through open surgery. People that have minimally invasive surgery are much more likely to get back to their everyday activities, such as walking, biking, and jogging, after minimally invasive surgery than via open surgery, where you have the longer incision. Smaller incisions leads to less time in the hospital and more time with loved ones at home. When you have less pain after surgery, that often leads to less narcotic pain medication prescriptions needed after surgery. Now, this is my favorite slide because we do a large amount of robotic surgery here. Everybody asks me, what is the robot and what actually happens? Well, you can see on your slide here the picture of the robotic instrument that we use. It is just that. It's simply an instrument that allows us greater mobility inside the abdomen to fix these hernias through very small incisions. Dr. Toder, Dr. Heatherman, and myself all control the robot, but it allows us to do more complex surgeries through smaller incisions to lead to faster recovery. Now, every hernia surgery has its risks. Specific risks of incisional, ventral, umbilical, and inguinal hernia repair are recurrence. No hernia repair is 100%, but we think with the robotic approaches that we offer, we give the greatest chance of long-term success. There's always a risk anytime you do any surgery of injury to some of the other tissues in the area, such as the intestine. And when you use mesh to fix hernias, there's always a chance of problems with the mesh. That's very low risk. And we've been using this mesh or these meshes in these locations for a long period of time and have great outcomes. Specifically after inguinal or groin surgery, you can have something called urinary retention where some fluid builds up in the bladder, or there can be injury to the testicular nerves in the groin area. All the risks are very low after inguinal hernia. Sometimes with surgery, serious complications may occur up to and including death. Serious risks do include, but are not limited to, damage to the tissues or the organs, or conversion to other surgical techniques, which could result in longer operative time or increased complications. Any individual's outcome may depend on a number of factors, including, but not limited to, patient characteristics and/or disease characteristics. So as we start to wrap up this hernia seminar, we want to remind you that every patient and every hernia is unique. If you think you have a hernia, we recommend you talk with your surgeon to determine what is right for you. If you have any questions, we're going to open it up now to answer via the Q&A feature found at the bottom of your screen. And I'm going to leave this slide up, and thank you all very much for taking time out of your busy days to spend time with us talking about hernias. And you'll notice the green box on the right of your screen, which really sets this program apart, is that we have a specialized hernia coordinator named Zena Black that helps manage all of our hernia patients. Her number and her email is on the screen. If you have any questions, you can certainly contact her. So at this time, I'm going to invite Dr. Heatherman to come back on and help answer any questions that you have.
So the first question was, is hernia surgery safe for people who have a stoma or a colostomy? And yes, a lot of people who have those types of hernias, there are different types. There's something called a peristomal hernia, which is a hernia that happens near the stoma. And then they can have all the other types of hernias as well. So, certainly any type of hernia is going to be an individualized discussion with a certain provider, but we definitely fix those types of hernias on quite regularly. So it's something we certainly can address.
Hey, as we wait for other people to ask questions, I'm wondering if you guys want to talk a little bit about expected length of stay in the hospital and what recovery sort of looks like for the average patient.
So I'll talk a little bit. So in terms of most, groin hernias, inguinal hernias that are what we call day procedures, meaning you come in and go home the same day. The surgeries last not even really an hour. And people are feeling good really within a few days for the most part. Some people are going to be sore for a little bit longer, but every surgery is a little different depending on the size and shape and all that. But most patients for some of the simpler hernias that we perform don't even spend a single day in the hospital. Now, there are certainly different hernias and more complicated ones might spend some time in the hospital, but a lot of these procedures are done on basically what we consider an outpatient basis. Never have to come into the hospital, never other than to have the surgery and you go home the same day. So really that's one of the advantages we think of the minimally invasive approach is that really recovery is just faster. People have less pain and they're feeling much better.
There's a question here is how safe is surgery for elderly patients? That's something that you want to discuss with your surgeon in the office. And age is not always a determinant of how safe the surgery is. Sometimes younger people that have more comorbidities or are sicker are higher risk than even older people that are in good health. So we don't use age as any sort of cutoff, and we're certainly happy to talk to any patient about the risks of surgery.
Mm-hmm.
There's another one on here that says, oh, go ahead, Bob.
I'm sorry. I was going to say, we seem to have a question from Tom, who has got his hand up. And
yeah,
go ahead, sir. Oh, looks like we're unable to unmute him at this time. So, Tom, if you'd like to put your question in the Q&A box, the doctors would be happy to.
Can you hear me now?
Oh, there he is.
Can hear you. There we
Excellent. Go ahead, sir.
Okay. I was diagnosed with a hernia 20 years ago. I chose not to because I was worried about elective surgery. Now it's become quite large. I guess you call it a femoral hernia. I'm 82. I'm worried about the age, which I didn't quite hear the answer to that previous question. But can your robotic non-invasive surgery handle a fairly large hernia?
So we do a lot of very large hernias with the robotic technique. It sort of depends, again, each of these is a little bit of an individual discussion about what's best for each patient. And even though we do a lot of minimally invasive surgery, for some patients, if they sometimes doing the old-fashioned open surgery is actually the better choice. As Dr. Sharbo was saying, age is just a number and everyone has their own, set of, health conditions and all of these things that basically impact, all of these sort of choices that we have. So I think it's an important conversation. And if you're thinking it's something that's bothering you and you want to have one of us address it, we're always happy to see you and talk to you. And you can always decide to continue to live with it, right? I mean, but we're always happy to have that conversation with you and kind of give you an assessment that we think, whether it's the right thing or not.
There's a couple more questions in the chat box here. What is the average cost for umbilical hernia? That's a question that us surgeons don't often know the answer to, and that's really something that often depends on insurance. And so we recommend that you either talk to your insurance company or you can email one of the people on the presentation here to direct you to someone who would better know the answer to that question. The second part of that question is, can it be outpatient? And for most umbilical hernias, the answer is yes. We do the vast majority of those as an outpatient, meaning you come in, get surgery, and you go home the same day. And so that's a fairly standard for umbilical hernia. The next question here says, I have a beer belly and have been labeled by my primary care provider as having an umbilical hernia. Are those two the same thing? Not really. What the typical public thinks of as a beer belly is more tissue in the middle of the abdomen causing a protrusion. But at the belly button itself is where the hernia is. And that's inside the belly button is where tissue from the inside is actually bulging through the abdominal wall. And that is the umbilical hernia.
There's a couple of questions in the Q&A, so I'm going to address those. So John asked if there were any drawbacks or risks to trusses. He says umbilical. So trusses, for those who don't know, are essentially a support band or a support device that helps kind of hold the hernia in. And it can help people make it more comfortable so that it's less discomforting. And there's no real risk per se to a truss. The risk of using a truss and not fixing the hernia is that generally over time, they tend to get larger and might cause more symptoms or cause a complication, as Dr. Sharbo was talking about earlier. So there's no per se risk to the truss itself. And I oftentimes encourage people to use them before we fix something, because it can help them feel better. So if they have one and they use it and it works for you, I encourage you to keep using it. The next question was, how far out are appointments? In our office, after somebody gets a referral, most people can be seen pretty much within a week, give or take a couple of days, but pretty much within a week. And then how long after an appointment does one have to wait till surgery? That'll depend a little bit on the type of hernia and, just the timing of, especially the summertime, some of us take a week off here and there. So sometimes we all like to enjoy the Maine summers, but generally I'd say most people are a couple weeks to a month or so, give or take a little bit. There's always a little bit of variability there. Who or what determines the type of surgery one gets, the insurance company, the doctor? That's entirely a discussion between the patient, yourself, and us. And I've never done a surgery another way because an insurance company said, they had an opinion about it. Do what we think is best for each individual, and I think that's the important thing. Is there a workout, physical therapy option to strengthen / lessen the bulge area? How many layers of muscle must the bulge inguinal protrude through? So
That's a good question.
Let me tackle the last question first. So there are four layers of muscles in our abdominal wall. And essentially in the groin area, there's several different layers with different weak points that basically are developmental. And oftentimes when somebody has a hernia, there's actually only one of those four layers kind of still intact. And essentially that's what's protruding out. So, but there are different types where there's different rules and different things apply. So that's sort of specific to inguinal. But ultimately, strengthening your core and doing physical therapy can help, may help it feel better, it may help strengthen the muscles. But usually that hole, once it's formed, it's unfortunately not going to go away. So it really won't lessen the bulge per se. And in fact, oftentimes people notice that when they work out and they're more active, sometimes those bulges are larger because that pressure forces things into the hernia, and that can actually make it look bigger. So unfortunately, working out physical therapy doesn't, actually resolve a hernia. It's one of the few things that we can say, like, it's not going to go away on its own. Oh, you're welcome. You have a great day. Yeah, the out of work time. So, recovery, it's a little different depending on the different types of hernias. So for inguinal and groin hernias, we do robotically. We basically recommend about 2 weeks of no heavy lifting. And what we mean by that is about 10 to 15 pounds. We don't want you straining and putting a lot of stress on that area. In terms of when people can go back to work, it really depends. I did somebody last week who was back to work on Monday. It really depends what you do and how much you're willing to, just go out and do it. Some people, if they do a lot of physical labor and a lot of lifting, they usually will have to be out for a couple of weeks while we're waiting for things to heal, so we don't want the hernia to just come right back. But if we do some larger hernias or some of the what we call ventral hernias in the middle, a lot of times we take a little bit longer because we want to make sure that those heal a little bit better because they're a little bit different in terms of how they're can be healed. The next question has to do with inguinal hernias, and it says, when I lie down, the hernia goes flush and is not noticeable. Will this type of hernia get bigger over time? So the answer with all of these is usually, everyone's a little bit different. Not all of them are going to get bigger over time. Some people will have a hernia for many years that never really changes. Other people will have it for a year and it will get much larger very quickly. What when that hernia goes back down, we call that reducing the hernia, right? So you lie back down and the hernia, all the stuff kind of falls out of it. But generally over time, as more stress and more pressure builds behind that weak point, it'll gradually get larger. That's, I can't say that definitively, but generally speaking, that's the case.
Dr. Sharma or Dr. Heatherman, I have a question here that came in from a member of the public last night prior to tonight's session. And this gentleman asked or states, 10 years ago, my physician noticed a bulge. I'm sharing this because it could be helpful to others that are on the call. 10 years ago, my physician noticed a bulge on one side and said we should keep an eye on it. Never had any pain or it never got larger until I strained it shoveling snow this past winter. Had pains for only a few days, but the bulge stayed larger. I'm in generally good health, no meds in my routine. Should I wait for pain to return before I consider this to be a problem?
Yeah, so we deal with this a lot, and I have this conversation all the time about, especially particularly groin hernias, that they're just a bulge, as Dr. Sharma was saying. Sometimes they're not causing a lot of discomfort or pain, and people just don't want to run to have surgery because life goes on and there's stuff going on. And what I tell everyone, I have this conversation, I said, there's no necessarily rush, right? Like you've had it for 10 years, right? So do you have to run to have it fixed tomorrow? No. But, I tell them is that those hernias generally, number one, aren't going to go away. They're probably going to continue to get bigger, as it did with that gentleman when he was shoveling snow. And generally over time, as we age, we get sicker and the hernias get bigger. And I tell people, if you're thinking about getting it fixed, it's always easier when it's smaller and you're healthier. So, I tell people, do you have to have it done tomorrow? No. Find a good time, right? We have a downtime, some point in the year that oftentimes is a great time to do it. But, I generally tell people, anytime that the hernia is there and it's causing symptoms or has caused symptoms, those are reasons to fix it because it's not going to get better.
And I believe we have Tom with another question, yes. A follow-up question.
Go for it.
I would like to know the percentage of strangulation that occurs in hernias and when they become life-threatening.
Yeah. So the quoted rate that we get from big studies that were done basically is that the risk of something getting strangulated, when what we see is two terms here. So there's a term called incarceration, which means stuck, right? Something is stuck in the hernia and won't come out. And then strangulation, which is if a piece of intestine got stuck in there and the blood flow to that intestine got compromised. Now, those are rare, but they can happen. And the rate for groin hernias specifically is about 1% per year. So what does that mean? That means if you have a groin hernia, the risk of something getting stuck in there, if you have it for 10 years, is roughly 10%. So, it's a little bit hard to say, but the rate is about 1% per year that you have a groin hernia. So does that make sense? Does that? Oh, he hung up on me, sorry. When diagnosing my inguinal hernia documents in my right elaborate. So any question like this, so I tell you there are different reasons for this. So there's a question about testicles being of unequal height. And sometimes that's just natural and that's how people are. Raised testicle is not necessarily an issue at all and may or may not be related in any way, shape, or form to a hernia. So the short answer is it's a little hard to say, but most likely those things are unrelated. The most comfortable truss I would recommend is the one that works best for you, because I honestly don't know all of them. I know a lot of people, you find them on Amazon and Walmart, and those are some of the places we usually recommend for people who are looking, but there's a ton of them out there. And if you find one that works for you, use it, but I don't have any stellar recommendations. I said, my recommendation would usually be fix it, and then you have to wear the truss. think we got somebody else with a hand raised, John.
Yes, yeah. All right, John, go ahead if you, oh, there you go. Try that again. John,
still
go
there you go.
Yeah, there you go.
Okay, you guys can hear me now?
We can.
Yeah.
Go ahead, John.
Yeah. Okay. I have a question. I've had 3 hernia operations, 2 of them through incisions and 1 laparoscopic. And I guess my question basically focuses on after effects. What about meshes? I mean, do you recommend once you have a hernia repaired that you take the other mesh out, or do you leave the mesh in there? And as far as I know, I probably have as many as 3 meshes in me.
Yeah. So mesh, Dr. Sharbo mentioned this a little bit. Mesh is, you know, obviously a lot of people see ads on the internet and commercials on television, and there's a lot out there about mesh. And what I say to most people is the mesh is, this is actually what mesh was originally designed for, right? It was originally designed to be used for hernia repair. It's been used like this for a long time, and it's generally very safe for these. In terms of taking out old mesh so I'm going to use a specific example because you kind of mentioned it. So if you have a recurrence of your hernia, when we fix hernias in the groin, open and laparoscopic, I describe it sort of like the abdominal wall is kind of like layers of a sandwich, right? So if you have, the bread on the outside and a whole bunch of meat and cheese and all whatever, tomato, lettuce, whatever you want in the middle, right? And there's a whole bunch of different layers. So when you do an open hernia, if this is the top, right, we kind of open up the top bread and we slide a slice of cheese in there on the top, okay? And then we close the top. When we do it robotically, we kind of put the cheese on near the other piece of bread. And there's a bunch of stuff in between, right? So they're not necessarily touching. So sometimes when we do it one way or the other, we won't necessarily take out old mesh. Having discussions about taking out old mesh is, a whole particular conversation, and I won't get into that further, but it's something to kind of talk about with a physician if there's a concern for some reason to talk about with any of us. So. Dr. Toder, you have a question?
No.
Your hand is raised.
My hand is raised. Oh, there we go. No, but I guess if you've called on me, I have a comment.
Yes,
we had some questions about, how quickly can I get this repaired and how fast can I get back to my usual activities? And I think there's a little bit of work patients can do on the front end to expedite their trip to the operating room if that's appropriate for them. And those include things like if you're a smoker, stop smoking. It's amazing what a difference it will make in terms of your postoperative recovery and your ability to heal. If you're diabetic, make sure that your diabetes is well controlled, hopefully with a hemoglobin A1C of somewhere around 8 or less. If you have a little extra weight around, focusing on good weight management is a great idea. And if your mobility is a little bit challenged, doing the best you can to be as active safely as possible are going to help you recover afterwards. So I think some of those things are really helpful if you're considering surgery in terms of getting the surgery as quickly and safely as possible.
Yep. Great. Thank you. So we have a couple more questions. So when having an umbilical hernia repair, how long is it before you can do activities such as swimming? So we usually recommend people wait a little bit of time before soaking their wounds in water. For an umbilical hernia, my usual answer is around a week. So it's not a terribly long time, but we just don't want you to be soaking wounds that are surgical in water right away because we don't want them to get infected. So as long as they heal well, I usually tell people about a week, you can get back to swimming and doing that kind of stuff. It's a little bit different depending on the type of hernia again. So, those are a little bit individualized, but if you have an appointment and you're concerned about when can I swim or when can I jump in the hot tub or whatever it is for enjoying the life in the summer, always encourage you to ask that physician. Is a follow-up doctor visit recommended before returning to work? Not necessarily. So, like I said, a lot of patients go back kind of a couple days after the surgery and go back to work right away. We oftentimes have to write people notes for, lifting restrictions and that kind of stuff. We're always happy to do that kind of thing. Usually we'll see everyone back roughly 2 to 3 weeks after surgery. It's a little bit variable again, but somewhere in that time frame, we'll see you back, make sure that the wounds are looking okay, that you're feeling good, all those things. And obviously, if anything happens in between, then we call the office, and we have Zena who helps us out with this, and all of us will answer those phone calls and get back to patients. And but a lot of patients go back, but between the time of surgery and the time we see them back in the office, they're already back working and doing stuff. Yeah, I wish I knew the answer to that question. Probably, right? It's just something you did, some sort of, so the question is, sorry, I don't know if anyone can see it. Why on some days may a groin hernia cause pain, and on other days you don't even know it's there? And I basically, my answer to that is usually that probably something happened where you're more active or more physical or strained in some way, that something got a little irritated. And it's a little hard to say, exactly what's going to be causing each individual's pain. Some people have different symptoms, but that's generally the answer to that. What determines the type of mesh used, and is it always used? The type of mesh, let me answer it. So is mesh always used? The answer is generally, for most hernias that are of any significant size. Hernia mesh is used because we know that it decreases the chances of hernias coming back. Particularly in the groins, that's the case. Sometimes if you have people with very small belly button hernias and stuff like that, we know that if your hernia is less than basically a centimeter, it's a small hernia, but some people will come with those small hernias for your belly button. We oftentimes will fix those just with stitches. We stitch them up and don't put mesh in there. So it sort of depends on the hernia. It depends on the size of the hernia. So all of those are a little bit variable, I guess, is the answer to your question.
We've had great Q&A from everyone. Appreciate your great questions tonight. And to thank you there for our doctors and your sharing your knowledge with everyone. We'll put a final call out here for any last questions. If anyone has any at all. Here we go, there's one.
So another question on wait time, but it's a little hard to say exactly. I'd say a month-ish, give or take. After you've seen one of us in the office, which doesn't take very long, usually about a week-ish or even less, then it's usually about a month, give or take a little bit, to get surgery scheduled. There's a sort of a follow-up about how do they do a surgery that is underneath for a stoma colostomy. And I would just say we have ways of kind of wrapping things and splitting things. So I'd encourage you to talk to one of us about it more personally. It's a little bit hard to explain on Zoom, but there are ways of doing it that we'd be happy to explain. Is a chicken-sized inguinal hernia considered large?
There's a follow-up to that.
Chicken-sized egg. A chicken-sized inguinal hernia, I would say, is definitely a large hernia. A chicken egg-sized inguinal hernia is probably a pretty much normal size one. How many folks are on this call? Well, I think we had somewhere around 30 people that joined us today, and plus our panel here, so in that ballpark. Some people do take some stool softeners. So the question about taking some laxatives after surgery. Some people oftentimes after surgery will get some constipation. That's not uncommon. We often recommend taking a stool softener to help move things along. That's quite normal. Not necessarily because anything to do with hernia surgery, just surgery in general, and getting medications for anesthesia can cause some of that. Well, I think unless there are any other questions, I think we'll probably wrap things up. I want to thank everyone for coming in and spending your time with us. Oh, I see another hand. Hold on.
Okay, I have one last question. General anesthetic, how often do you get general anesthetic? And are you put under?
So it depends a little bit. So for robotic surgery, all of those are done under general anesthesia because you do need to go completely to sleep to do that type of surgery. Some open surgery can be done under some types of anesthesia that are less than general anesthesia, but that is, again, going to be a specific question for each individual patient, and it has to do more with the type of surgery as well as the risk factors for each of the individual person. If you send us a message, we might be able to work on that. There's a question about getting a referral of somebody who doesn't have a primary care. I'm assuming we can work on it. So if you send us a message, we can probably try and figure out how to get you in as soon as we can.
All right. Any parting thoughts from any of our physicians or Tom, anyone?
We just want to say thank you so much for everybody coming out tonight and listening to our short webinar on hernias. We hope you learned something, and we hope to see you soon.
Yep. Thanks again.
Thank you.
All right. Thanks, everyone. Feel free to contact Zena if you have any questions. And also just another quick reminder that we do have a very brief, it's like 10-question survey that will pop up on your screen after you exit the presentation. So if you would just take a moment to complete that, we would appreciate it so much. Thank you for being with us, and please be safe and well.